Hello and welcome to the Point of Care podcast. Today's Quick Admit episode is a rapid review on the evaluation of vertigo and dizziness in a hospital setting. The primary goal when evaluating a dizzy patient is to differentiate dangerous central causes from more benign peripheral or systemic etiologies. Do not rely on the patient's description of their dizziness, such as spinning versus lightheaded. Instead, your focus should be on the timing and triggers to build your differential diagnosis. The most effective approach is to divide the presentation into clinical syndromes. Either acute vestibular syndrome, or AVS, which is continuous dizziness lasting more than 24 hours, or episodic vestibular syndrome, which involves transient recurrent attacks. For patients with acute vestibular syndrome, a stroke is the main concern. The HINTS exam, which stands for Head Impulse, Nystagmus, and Test of Skew, is your most powerful tool. It's actually more sensitive than an early MRI for posterior circulation stroke. Any single dangerous finding, like a normal head impulse, direction-changing nystagmus, or a positive test of skew, should prompt an urgent MRI or MRA and a neurology consultation. Also remember that a patient's inability to stand or walk unassisted is a major red flag for a central cause. For patients with episodic vestibular syndrome, you need to determine if the episodes are triggered or spontaneous. If they're triggered by position changes and last for seconds, suspect BPPV and confirm it with a Dix-Hallpike maneuver. If triggered by standing up, check orthostatic vital signs. If the episodes are spontaneous, consider vestibular migraine or a TIA, especially in patients with vascular risk factors. And for every dizzy patient, you must perform a thorough neurologic exam to screen for the 5 Ds: diplopia, dysarthria, dysphagia, dysmetria, and sudden deafness. These symptoms point toward a brainstem or cerebellar lesion. Now let's break down the admission and evaluation process, starting with the immediate assessment. First, assess for any signs of hemodynamic instability or neurologic compromise. For the airway, ensure the patient can protect their airway, which is especially important if their mental status is altered or if they're vomiting. For breathing, assess for hypoxia. This could suggest a serious underlying cause like a pulmonary embolism or acute coronary syndrome. And for circulation, check for hypotension, which could be from hemorrhage, sepsis, or orthostasis. Also look for bradycardia or tachycardia that might indicate an arrhythmia. The first and most critical step in categorizing dizziness is to establish the timing and pattern. Key questions to ask include, when exactly did this dizziness first begin? Did it start suddenly over seconds, or did it come on more gradually over hours or days? And since it started, has the dizziness been constant and continuous, or does it come and go in spells? If the patient reports continuous dizziness, you're dealing with acute vestibular syndrome. You need to ask how long it's been present for without stopping, and whether moving their head makes the constant dizziness worse, or if it triggers a brand new spell. This distinction between exacerbation and a new trigger is key. If the dizziness comes and goes, it's an episodic vestibular syndrome. You should ask how long a typical spell lasts, seconds, minutes, or hours, and how frequently these spells happen, daily, weekly, or monthly. Next, for episodic spells, you need to investigate the triggers. Ask the patient what seems to bring on a spell. Is it triggered by a change in position, like rolling over in bed, lying down, or looking up? This suggests BPPV. Does it happen specifically when they stand up from a sitting or lying position? This points to orthostatic hypotension. Or do the spells happen spontaneously without any specific trigger? This suggests possibilities like vestibular migraine, Meniere's disease, or a TIA. You should also ask about less common triggers like coughing, sneezing, or straining. While less reliable for diagnosis, understanding the symptom quality helps build the clinical picture. Ask the patient which of these best describes their feeling: a sensation of spinning, which is vertigo, feeling lightheaded like they might faint, which is presyncope, or feeling unsteady and off balance on their feet, which is disequilibrium. Moving on, you must screen for associated neurological symptoms or red flags. This is where you screen for those 5 Ds. Ask the patient if during these spells they've had any new, sudden, or severe headache, especially in the back of their head. Have they experienced diplopia, or double vision, dysarthria, or slurred speech, dysphagia, or difficulty swallowing, and dysmetria, which is clumsiness or poor coordination. Also ask about any focal weakness or numbness, especially on one side of the body. Next, ask about associated otologic and systemic symptoms. Inquire about any changes in hearing. If yes, is it in one ear or both? And is the hearing loss constant or does it fluctuate with the dizzy spells? This could suggest Meniere's or labyrinthitis. Also ask about tinnitus or a sense of fullness in one ear. Other important questions include asking about nausea, vomiting, chest pain, shortness of breath, palpitations, or recent fever or viral illness. It's also crucial to understand the severity and functional impact. Ask the patient to rate the dizziness on a scale of 0 to 10. Find out if they're able to walk without help when the dizziness is at its worst. If they can't walk, can they at least sit up straight without support? An inability to sit or stand unaided is a major red flag for a central cause. Also ask if they've fallen because of the dizziness. Finally, review the patient's history, risk factors, and medications. Ask about any prior episodes. Review their cardiovascular risk factors like hypertension, high cholesterol, diabetes, AFib, or a previous stroke or TIA. Ask about a personal or family history of migraine headaches. And check for any recent head or neck trauma. Ask about any history of anxiety, panic attacks, or depression. Then carefully review all current medications, including over-the-counter drugs. Focus on antihypertensives, diuretics, aminoglycosides, sedatives, and antidepressants. Ask about any new medications or recent dose changes, and don't forget to ask about alcohol, cannabis, or other substance use. A targeted physical exam is critical. Start with vitals, including orthostatic blood pressure and heart rate. Measure after the patient has been lying supine for 5 minutes and then again at 1 and 3 minutes after standing. Also check for fever and hypoxia. On the general exam, look for pallor, sweating, or signs of dehydration. The neurological exam is the most important component. For patients with continuous dizziness or acute vestibular syndrome, you must perform the HINTS exam. The first part is the head impulse test. The patient fixates on your nose and you rapidly turn their head about 15 degrees to one side. A corrective saccade, where their eyes jump back to the target, is an abnormal but reassuring finding, as it suggests a peripheral lesion. A normal test, where the eyes stay fixed on the target, is worrisome for a central cause. The second part is assessing for nystagmus. Observe the patient's eyes in primary and then right and left gaze. Note the direction. Peripheral nystagmus is typically unidirectional, horizontal, and suppressed by visual fixation. Central nystagmus, on the other hand, can be bidirectional, purely vertical or torsional, and is not suppressed by fixation. The third part is the test of skew. This is an alternate cover test. If you see vertical realignment of the eye when you uncover it, that is an abnormal and worrisome finding for a brainstem lesion. Beyond the HINTS exam, you need to assess the cranial nerves for any facial droop, dysarthria, or dysphagia. Check cerebellar function with finger-to-nose and heel-to-shin testing and assess the patient's gait. For patients with triggered episodic vertigo, you'll need to perform provocative maneuvers. The Dix-Hallpike maneuver is used to diagnose posterior canal BPPV. A positive test will elicit transient, upbeat torsional nystagmus that typically lasts less than 60 seconds. Finally, perform a thorough cardiac exam listening for murmurs, rubs, gallops, or an irregular rhythm. Your differential diagnosis should be broad. Peripheral vestibular causes include BPPV, vestibular neuritis, labyrinthitis, Meniere's disease, and vestibular migraine. Central vestibular causes include a posterior circulation stroke, TIA, vertebral artery dissection, multiple sclerosis, or a posterior fossa tumor. Cardiovascular causes can be orthostatic hypotension, an arrhythmia, acute coronary syndrome, severe aortic stenosis, or a pulmonary embolism. And systemic or other causes include dehydration, hemorrhage, sepsis, anemia, hypoglycemia, medication side effects, or even carbon monoxide poisoning. Your initial order should reflect your primary concerns. An EKG should be performed on all patients. For imaging, An MRI/MRA of the brain and neck is the test of choice for a suspected central cause. It's much more sensitive than a CT scan for posterior fossa pathology. A CTA of the head and neck is useful if you're concerned about a vascular dissection. A non-contrast head CT has limited utility for acute ischemic stroke, but can effectively rule out a hemorrhage. For initial treatment, if you suspect a stroke, activate your institution's stroke protocol. If BPPV is confirmed by a Dix-Hallpike test, perform the Epley maneuver. For orthostasis, provide IV fluids and hold any offending medications. For symptomatic relief of peripheral vertigo, you can consider short-term vestibular suppressants. This may include antihistamines like meclizine or benzodiazepines like lorazepam for severe vertigo, but use these sparingly and for less than 72 hours. Antiemetics like ondansetron can also be very helpful. And most importantly, place all patient on strict fall precautions. That's all for this episode. Check out pointofcaremedicine.com to learn more.